Welcome to this third lecture on the neck triangles. In this particular lecture, we are going to look at the suprahyoid anterior neck triangles as well as the suprahyoid neck spaces. Just to put this to perspective, remember we are doing a series on the neck triangles. So we've done the first part, which focused on the posterior neck triangles. We've also done the second part, which focused on the infrahyoid anterior neck triangles. And in that particular place, we looked at carotid triangle as well as the muscular triangle. But in the same lecture, we also looked at the infrahyoid neck spaces. So in this third lecture, we are looking at the suprahyoid anterior neck triangles, but we'll also look at the suprahyoid neck spaces. Generally, this is part of the bigger lectures on head and neck that you're doing as well. And I've called this session 5 because session 5 is where we focused on the neck triangles. So just to remind us about what perhaps we should be already knowing, especially if you've been following the first two parts of these lectures on the neck triangles. We have the anterior neck triangle, which is bounded by the following. So we have the anterior border of sternocleidomastoid muscle there. We have the midline of the neck. And we have the inferior border of the mandible. So those three basically define for us the territory of the anterior neck triangle. There are some things which are within the triangle that divide this anterior neck triangle into some 4 smaller triangles. One of them is the muscle digastric with its anterior belly there and posterior belly there. The second muscle is this one, the stylohyoid muscle. Of course, this is the hyoid bone, and this is the superior belly of the omohyoid muscle. So those structures divide the anterior neck triangle into some smaller triangles. For example, this one is the muscular triangle, and this one is the carotid triangle. So those two, we covered them when we looked at the infrahyoid anterior neck triangles. As we can see, they're below the hyoid bone. We have this triangle here being the digastric triangle, and the triangle here being the submental triangle. And those two in green are the ones which we're going to focus in this particular lecture as part of suprahyoid neck triangles. This is just another diagram to show you the 4 subtriangles of the anterior neck triangle. We have the digastric triangle, submental triangle, carotid triangle, and muscular triangle. Of course, if you've been following, you remember this is the posterior neck triangle, which also has 2 divisions, the occipital triangle above and the subclavian triangle below. This image shows you again the muscular triangle and carotid triangle as part of infrahyoid anterior neck triangles, and submental triangle and digastric triangle as part of the suprahyoid anterior neck triangles. Traditionally, the neck has been divided into triangular anatomy, and this is useful generally in terms of when we inspect the neck, we're able to use these landmarks. For example, sternocleidomastoid to tell us this is now the posterior triangle or this is the anterior triangle. We can also palpate some of these structures, like the hyoid bone, we can palpate it. Sternocleidomastoid definitely can be palpated. The mandible can be palpated, and you can use this one as well as landmarks. During surgery, there are many more structures that you can see. For example, the omohyoid can be seen. the digastric can be seen. And so they're usually used as landmarks in clinical procedures as well. There's a challenge, however, with this triangular anatomy of the neck, because the triangles have a craniocaudal orientation, which means that they extend from above going down. This makes it really difficult to interpret them or to correlate them with imaging of the neck, because imaging the neck is usually done. The CT and MRI image in the neck are usually done based on axial images, a cross-section image, a transverse image of the neck. So because the triangles have a craniocaudal orientation, but the images have a transverse orientation, they're a bit difficult to correlate. And it's because of this that we then come up with the spatial anatomy of the neck. The spatial anatomy of the neck refers to a series of some anatomical spaces within the neck. These anatomical spaces are defined or limited by the layers of the cervical fascial system, and especially the deep cervical fascial system. So because of these spaces limited by this fascial system, we can be able to see these spaces on axial images, and so we can really easily correlate them and also be able to describe them well using CT scan and using MRI. So because of this, we will also discuss the spatial anatomy of the neck. And in the previous lecture, we focused on the infrahyoid neck spaces. I explained this concept. In this particular lecture, we are going to focus on the suprahyoid neck spaces. Maybe just remind you about the fascial anatomy of the neck so that you remember when we discuss now the spaces, it will be easier for you. It will be difficult if you don't understand the fascial system. So we have superficial fascia of the neck that is surrounding the whole neck. And on the superficial fascia, you have a number of structures. So generally, these structures will be subcutaneous structures. Important to mention that this is where platysma also lies in the neck, and especially the anterior neck. But we also have subcutaneous blood vessels, and in particular, remember the external jugular vein running within the subcutaneous tissue. We also have the cutaneous nerves, which terminate in the skin in the neck, and so there'll be superficial structures. Well, deep to the superficial fascia is the deep fascial system of the neck. And the deep fascial system of the neck is quite extensive and relatively complex. We talk about 4 components of the deep fascial system of the neck, 4 components of the deep cervical fascia. So we have layer system, and we can describe them in terms of 3 layers, and their union constitute the 4th component. On the first image, the outlined in blue represent the superficial layer of the deep cervical fascia. And this superficial layer of the deep cervical fascia is what we call the investing fascia. So that's the outermost of the deep cervical fascia. The investing fascia is quite extensive and also encloses a number of muscles like sternocleidomastoid, trapezius. On the suprahyoid neck, it encloses the muscles of mastication, it encloses the submandibular gland, it encloses the parotid gland. Usually it might split to actually enclose them. The second layer of the deep cervical fascia, the one in the middle here outlined in red, is the visceral layer of the deep cervical fascia. You can call the middle layer of the deep cervical fascia or the visceral fascia, commonly called the pretracheal fascia. So the pretracheal fascia encloses the strap muscles as well as enclosing the visceral structures of the inferior neck, as you can see. Superiorly, it will be around the pharynx. generally speaking. And then you go to the deep layer of the deep cervical fascia. And the deep layer of the deep cervical fascia is what we call the prevertebral fascia. This fascia generally encloses the vertebral column and the muscles of the vertebral column. And as you can see it here, this is the prevertebral fascia. The union of the three fascia occurs around the regions of the common carotid artery and the internal jugular vein. And that union forms the fourth component of the deep cervical fascia, which we call the carotid sheath, the one outlined in green. So this carotid sheath is a union of the other three deep cervical fascial systems. So that is important because we are going to use this fascial anatomy to discuss the spatial anatomy of the neck. And so with that in mind, I can now give you the objectives of this particular lecture. We'll first look at the boundaries, contents, and perhaps clinical relevance of the submental neck triangle. We will then look at the boundaries, contents, and clinical relevance of the digastric neck triangle. The digastric triangle is also termed the submandibular triangle. So those two are the suprahyoid neck triangles that we are focusing on in this particular lecture. Considering the fact that this region, the suprahyoid neck, also has some important salivary glands, we'll talk about them. Remember that we have three major salivary glands: the parotid gland, the submandibular gland, and the sublingual gland. We discussed the parotid gland when we looked at the lecture on parotid region and facial nerve. And so you can revisit that at that particular point. It's a previous lecture we've done before. In this particular lecture, we look at the other two major salivary glands. So we look at gross anatomy and histology of the submandibular gland. We'll also look at gross anatomy and histology of the sublingual salivary gland. After that, we are going to then name the suprahyoid neck spaces and state the contents of each space. While we do that, we'll also talk about some special spaces like the infratemporal fossa. We'll talk about that at that particular point. Lastly, we will have a summary or a review of the major neurovascular structures of the suprahyoid neck. Most of these neurovascular structures, we've already covered them in the previous session. So just mention them, but not quite discuss them. You can revisit the previous lectures to understand more about them. We can then begin with the first agenda, which are the boundaries, contents, and clinical relevance of the submental neck triangle. We can begin with the boundaries of the submental triangle. So this is an image from the anterior neck, both right and left, displaying the anterior neck triangles, and we are focusing on this region here. So the submental triangle has a base that is posterior, and the base is formed by the body of the hide bone, as you can see there. It also has some sides. So there's a right and a left side, which are general anterolateral. The anterolateral boundaries are formed by the anterior bellies of the right and the left digastric muscle. Now, let me mention something here. There are different perspectives into the understanding of the extents of the submental triangle. You can consider submental triangle to be just one triangle in the middle. In this case, we'll talk about the base being the hide bone and the anterolateral boundary being the anterior bellies of the digastric, and you're done, because you have right and left. But you can also look at submental triangle as just a triangle on one side. So in which case, then you'll say that we have two submental triangles, the right and the left submental triangle. If that is your approach, then you'll introduce this one as a boundary, the midline of the neck. And so you have this triangle and that triangle. Either way, the concept will be that you know where the submental triangle is found and you know the contents there. And you know that the right and the left continue with each other without any boundary, because that midline is an imaginary line. So in this particular case, you can consider that to be the left submental triangle. The floor of the submental triangle is formed by the mylohyoid muscles. So you look at the right and left mylohyoid muscle to form the floor. This is the mylohyoid muscle that you're talking about as forming the floor. That's the right and that's the left. What are the contents of this triangle? The key content of the triangle are basically the origin of the anterior jugular veins. We've talked about anterior jugular veins in our previous lecture. So the origin is around there. We also have the submental group of cervical lymph nodes. If you remember from the previous lecture, this is the level 1A of cervical lymph nodes. This level 1A of cervical lymph nodes generally drain the lower lip. They also drain the tip of the tongue and the anterior floor of the mouth. And so if you have pathologies in this particular region, you may have enlargement of the submental lymph nodes. That is the submental triangle. We can now go to the second agenda, talking about the submandibular triangle, also known as the digastric triangle. And this is a triangle. The digastric triangle has the following boundaries. So superiorly, we have the base of the mandibular body there. We can extend this posteriorly by an imaginary line from the angle of the mouth there to the, from the angle of the mandible there to the level of the mastoid process. So that becomes the base of the triangle. Then posterior and inferiorly, so posterior and inferior, we have these two muscles, the stylohyoid muscle and the posterior baleo-digastric muscle. And then anterior inferiorly, we have the anterior belly of the digastric muscle. So this is the space we're talking about. This is the triangle we're talking about. The floor of this triangle is still formed by a mylohyoid muscle, but this is also an additional muscle, the hyoglossus muscle. So this is mylohyoid muscle still. A bit posterior to that is the hyoglossus muscle, which you see part of it there or in this particular region there. So this also forms part of the floor of this triangle. Superficially, the triangle will be covered with superficial fascia, as we expect. And in that superficial fascia, we expect a number of things, including platysma, which you can see in this particular view. These are the fibers of platysma muscle, which is subcutaneous. On that superficial fascia, we also expect to have the cervical branch of the facial nerve that supplies the platysma muscle. We also expect to have the transverse cutaneous nerve, the neck that grows to supply the skin over this region. What are the contents of the submandibular triangle? The submandibular triangle has contents, and the contents are a bit different when you look at it from the anterior aspect and from the posterior aspect, and I'll divide it as so. So the anterior part, and which is mainly the larger part of the triangle, has the submandibular gland, as you can see there. Also, it has the facial vessels, so the facial artery and the facial vein cross in this particular region, as we can see there. We have the submental artery. The submental artery is a branch of the facial artery, so usually it crosses into this particular region crossing from the submandibular triangle through to all the way towards the submental region as well. And this image shows you that branch of the facial artery. So this is the facial artery, and that is the submental artery given there. We also have artery and nerve to mylohyoid muscle. The artery to mylohyoid muscle is coming way up from the maxillary artery seat, and the nerve to mylohyoid muscle is coming also way up from the mandibular nerve. We'll see that later. But in this image, so this is the mandibular nerve within a region we are calling the infratemporal fossa. We'll talk about it shortly. This nerve here you see is called the inferior alveolar nerve. And this inferior alveolar nerve is the one that gives you nerve to mylohyoid muscle. So this nerve to mylohyoid muscle will have an artery accompanying it, which is artery to mylohyoid muscle, or the mylohyoid artery. So they both run together towards the submandibular region to supply the muscle mylohyoid together with the anterior gastric muscle. This image captures that. So this is facial artery, and this is the submental artery, a branch of facial artery. But this is the neurovascular bundle, the mylohyoid neurovascular bundle. So we have a vessel and a nerve. This one come all the way from up. We'll trace them from up shortly. Right. In this particular region, we also expect to have the submandibular group of cervical lymph nodes. Remember, the submandibular group of cervical lymph nodes constitute the level 1B of cervical lymph nodes. This submandibular group of cervical lymph nodes also have extensive territory that they drain. They drain the floor of the mouth still, they drain the tongue, they drain the submandibular gland, they drain the sublingual gland, they drain the paranasal sinuses, they drain the nasal cavity itself. So quite extensive territory. This image shows you an example of a submandibular lymph node there. It's not usual to, it's not common to be seeing them enlarged, but occasionally they can be like this one. And this is part of the submandibular gland. So this is the submandibular group of lymph nodes shown in this particular image, and we can see the territory that they drain. In the posterior aspects of the submandibular triangle, we have the inferior part of the parotid gland, as you can see in this particular image, and you also have the external carotid artery also crossing the way posterior part of the triangle. So these are the contents of the digastric or the submandibular triangle, the neck. We can now focus on the submandibular gland itself. We'll talk about its gross anatomy as well as its histology. Okay, so in terms of gross anatomy, the submandibular gland is irregular in shape and is made up of two lobes. We have a superficial lobe and a deep lobe. As the name suggests, superficial lobe will be superficial and the deep lobe will be deep. The superficial lobe usually is continuous to the deep lobe, as you can see in this particular image, through this region here that wraps behind the muscle mylohyoid. So on the posterior border of mylohyoid muscle, the deep lobe and the superficial lobes of the submandibular gland are continuous generally. So it's actually just one gland, which has those two parts. The gland is surrounded by a capsule, as I mentioned earlier, and this capsule is actually formed by the split layers of the investing fascia of the neck, as I told you earlier. The investing fascia of the neck is the superficial layer of the deep cervical fascial system. As it ascends, it splits into two to enclose the submandibular gland. So there's a superficial lamina that will attach onto the inferior margin of the mandible, and a deep lamina that will attach onto the mylohyoid line of the mandible on the middle aspect of the mandibular body. So this sandwiches the submandibular gland there. Now I can tell you the actual location of the gland, although we already know, but let's put it into perspective. Considering that the gland has two lobes, the superficial lobe, which is the larger lobe, is the one located within the submandibular triangle. The deep lobe is not actually in the submandibular triangle, but it is located in what we call the sublingual space, and we'll see what sublingual space is shortly when you look at the suprahyoid neck spaces. So in this image, this is the superficial lobe, which is in the digastric triangle, as we can see. And this is the deep lobe, which is within the sublingual space. The sublingual space is basically this space below the tongue, and it has a number of structures, as you can see there, including the deep lobe of the submandibular gland. All right, now we can talk about the relational anatomy of the submandibular gland. We can start the relations of the superficial lobe. The superficial lobe can be described to have three important surfaces. The inferior surface, which is also the subcutaneous surface, or the surface near the subcutaneous region. And we also have the lateral surface and the medial surface. The surface you're seeing in this particular image is the inferior surface. This inferior surface is the one related to the deep fascia. The superficial layer of the deep fascia is about in this region. And of course, if you understand that, then you'll also understand that external to that, you'll have the superficial fascia, which contain the platysma muscle, facial vein, and the cervical branch of the seventh cranial nerve, which is facial nerve. So those would be the relations of the inferior surface of the gland. This image shows you that. You can see the investing fascia coming like this and splitting into two, as we had mentioned earlier. So this is the superficial or the inferior surface, as you can see there. And this is the lateral surface of the gland. This is the medial surface of the gland. So this inferior surface of the gland is related to these structures here. We have the facial vein. We have the cervical branch of facial nerve. We have platysma muscle as well. The lateral surface, which is this one, as you can see in this particular image, will be related to this side of the mandible. So remember, if this is the mandibular body, this is the lateral surface of the mandible. This is the medial surface of the mandible. On this medial surface of the mandible, there's a depression there made by the impression of the submandibular gland. We call this submandibular fossa. So the submandibular fossa of the body of the mandible is the lateral relation. You can see the fossa there. So that's the mylohyoid line for attachment of the deep lamina of the investing fascia. And the superficial lamina of the investing fascia attaches there. Now we can talk about the medial surface. This is the medial surface of the gland. And in this image, we can see a number of things. We can see the mylohyoid artery together with the nerve to mylohyoid. We can also see the mylohyoid muscle itself. So those are medial structures. In this particular image that I already shown you, this is the mylohyoid muscle, and this is the mylohyoid artery and nerve, which is on the middle aspect. So remember that the gland will be resting somewhere here. So in this particular view, we can also see other things. The submental artery, branch of facial artery, hypoglossal muscle, which is that one, the hypoglossal nerve, which is this one, the tendon of the posterior belly of the gastric, which is this one. The superficial part of the gland rests even lower down somewhere here, and so even the hide bone that rests somewhere here will also be partly a medial relation of the gland. In this particular image, we are able to capture what I've told you. In addition to that, we also have the lingual nerve, which we didn't see in that particular image because it is in the interface between the mylohyoid muscle and the hypoglossal muscle. So we didn't see it quite because also a bit up. What we saw was the hypoglossal nerve. And above the lingual nerve, we also expect to have the hypoglossal muscle. Again, we didn't see it in the previous image, but it's also a medial relation. But remember that at some point, the mylohyoid muscle separates those structures from the gland. But further posterior, those structures will be directly related to the gland because the mylohyoid muscle does not extend much posterior. And that's why we have the connection between the superficial and the deep part of the submandibular gland in that particular region. So in summary, if you look at the muscles which are on the medial surface, mylohyoid muscle, styloglossal muscle, hypoglossal muscle, and posterior belly digastric muscle. If you look at the vessels, you have the submental artery. We also have the deep lingual vein. The deep lingual vein is the one running with the hypoglossal nerve. And remember, we also mentioned the mylohyoid vessel. In terms of nerve, we have the nerve, hypoglossal nerve, which is the 12th cranial nerve. The lingual nerve is a branch of mandibular division of trigeminal. This lingual nerve usually has a ganglion on it, the submandibular ganglion. And so this ganglion is also a medial relation of the gland. And we have nerve to mylohyoid, which I've already talked about, a branch of the inferior alveolar nerve, which is a branch of the mandibular division of trigeminal. This image captures for you the lingual nerve coming down and having the submandibular ganglion. It also captures for you the styloglossal muscle that we've just talked about as being a medial relation. So consider that the gland is somewhere here. Hypoglossal is this one here. And mylohyoid muscle will be somewhere here. So the gland covers all this region. And so this is partly the relation anatomy. You can see the hypoglossal nerve with the deep lingual vein there. Right, now let's talk about the relations of the deep lobe. Perhaps we begin with its location first and its extent. So this is the deep lobe of the submandibular gland. It lies between the mylohyoid muscle, which is this one, and hypoglossal muscle, which is deep there. It continues with the superficial lobe through this particular connection behind the posterior border of mylohyoid muscle, as we can see. And as we already mentioned, anteriorly, it will extend to near the sublingual gland, which is this one here. So in terms of its relations, if the gland extends up to somewhere around this region here, then all these structures we're seeing here are actually relations of this particular deep lobe. we can talk about them, and as we can see them here. In this particular image, we can also see others. Okay, maybe let me just mention to you. So we can see we have the lingual nerve there and the submandibular ganglion there. We also have the lingual vessels there. We do have the hypoglossal nerve somewhere there. That is hypoglossal nerve. And of course, we also have much anteriorly, we have the sublingual gland there. The green one is a submandibular duct. Important to note is that the deep lobe continues the superficial lobe behind the border of posterior border of mylohyoid muscle, and that this gland is located between mylohyoid muscle laterally and hypoglossal muscle medially. That is important to capture. So that if you talk about the relations, the lateral relation, which is basically inferolateral relation, is mylohyoid muscle, and the medial relation is the hypoglossal muscle if you go much anterior, but if you extend this posteriorly, we'll talk about the styloglossal muscle, and we'll also talk about the lateral pharyngeal wall, and that will be quite more posterior. So this image shows you the site of the submandibular gland and the structures medial to it, irrespective of whether it's superficial lobe or deep lobe. And we can see many structures now, including even glossopharyngeal nerve, will be at some point a medial relation. The stylohyoid ligament will also be at some point a medial relation, but much posterior. I believe the other structures, we've already talked about them, and so you can capture them well there. This image shows us an axial image at the level of the submandibular gland, also to just try to appreciate the relation anatomy as well. Superficial part and the deep lobe there. You can see the closeness between the deep lobe and the sublingual gland. They're both in that particular space that we've called the sublingual space, and this is the submandibular space. The two are connected behind the posterior border of mylohyoid muscle. Also important to note that the submandibular gland is separated from the parotid gland by the stylomandibular ligament, that one. This is the one that separates now the parotid gland from the submandibular gland. Let's talk about the neurovascular supply to the submandibular gland. The arteries that supply the gland come from branches of facial nerve and branches of the lingual nerve. Sorry, branches of the facial artery and the branches of the lingual artery. So remember, facial and lingual arteries are branches of external carotid artery. They're the anterior branches. Lingual artery is the second anterior branch of external carotid. Facial artery is the third anterior branch of external carotid. So they have branches, several, and some of these branches go to the submandibular gland. The lymphatic vessels that come from the submandibular gland generally will drain to the submandibular group of lymph nodes, and then also drain to the deep cervical lymph nodes. Remember, the deep cervical lymph nodes, the jugular chain of lymph nodes. Basically, we have level 2, level 3, and level 4. So most of these lymphatics will go first to level 2 of deep cervical lymph nodes. In terms of nerve supply, we can look at it the way we looked at the one for parotid. Look at it in terms of secretomotor, vasomotor, and general sensory. The secretomotor innervation is the parasympathetic innervation. This is the one that causes the gland to produce secretions. The postganglionic parasympathetic fibers to this particular gland come from the submandibular ganglion. So the submandibular ganglion that has the postganglionic parasympathetic fibers to the submandibular gland, which cause the gland to produce secretion. But for these fibers to reach the submandibular ganglion, there must be preganglionic fibers. The preganglionic fibers of this particular pathway have a very long route. They start all the way from the superior salivatory nucleus in the brainstem. That is the location of the cell bodies of preganglionic fibers. And these fibers join the nervous intermediate route of facial nerve, and so they'll be part of facial nerve. Then within the petrous bone, when the facial nerve is passing through the ear, it will give you the chorda tympani branch. And so these preganglionic fibers follow the chorda tympani branch. Then the chorda tympani branch is the one that joins the lingual nerve. And so the preganglionic fibers are now within the lingual nerve. And that's how they find themselves to the submandibular ganglia. So in this image, we can see that what I've just told you, from the superior salivatory nucleus, the fibers will be within facial nerve. Then within the ear, facial nerve gives you the chorda tympani branch. This chorda tympani branch joins the lingual nerve, which is a branch of mandibular nerve. And so the preganglionic fibers will come and synapse in the submandibular ganglion. Then postganglionic parasympathetic fibers come from here to supply both the submandibular gland as well as the sublingual gland and even the intrinsic salivary glands in the tongue. That is basically the route of secretomotor innervation to the submandibular gland. The vasomotor innervation to the submandibular gland will rely on sympathetic innervation. The postganglionic fibers of this particular innervation come from the superior cervical ganglion, which is a ganglion in the neck there. From the superior cervical ganglion, postganglionic fibers usually will hitchhike on the blood vessels. And that is how they'll then reach eventually the submandibular gland, because in this case, they'll follow the blood vessels that eventually reach the gland as well. Remember, they are vasomotor, they cause vasoconstriction. The general sensory innervation will target the stromal tissue of the gland, as we mentioned, even in parotid. And this general sensory innervation is largely by the lingual nerve, which is a branch of mandibular nerve. So this is the lingual nerve from mandibular division of trigeminal. The general sensory fibers will go to the gland, as well as, of course, going to many other structures around this region. We can see that this very lingual nerve is the one that receives chorda tympani, even in that image. So that is neurovascular supply. We can now talk about the histologic organization of this particular gland. So in terms of histological organization of the submandibular gland, understand that this is an exocrine gland. And in general, an exocrine gland will have both stromal tissues as well as parenchymal tissue component. When you talk of stromal tissue component, we are referring to the connective tissue elements. And when you talk about the parenchymal tissue, we are referring to the functional component that produce the secretions. So in this case, just like any other major salivary gland, and we talked about this when we discussed parotid, the stromal tissue generally will offer supportive framework that they provide the structural support to the gland. So it consists of fibrous capsule that surrounds the gland. Remember, this is partly contributed by the investing fascia of the neck. And this capsule extends some connective tissue into the gland, which we call the septae or trabecula. The trabecula that extend into the gland will therefore subdivide the gland into lobules. As these connective tissue elements enter the gland, they carry with themselves blood vessels, lymphatics, nerves, and even some large ducts are usually found within the connective tissue elements. And so that is important to take note of the stromal tissue component. The parenchymal tissue component of a salivary gland in general consists of acini, which produce secretions. There would be two different types of acini histologically, the serous acini and the mucus acini. So a major salivary gland will have those two components of the acini, serous acini and mucus acini. But these are the ones that produce secretions. If you remember, we discussed this in great detail when we looked at parotid gland, and we even talked about something called the salivon, the functional secretory unit, where we have the acini that drain into a ductal system. And see the same concept here. I will not discuss much about the salivon in this particular lecture because we've already discussed in the previous one. So anyway, the ductal components will be draining saliva from the acini component. Now, when you look at the gland, so if this was capturing from outside, we'll also expect to see the capsular component, but it wasn't capturing. What we can see at the trabecular system, the septae, and these are the ones we can see there. The septae, we can also see some ducts, and these ducts are extralobular, as you can see. They're within the stromal tissue component. The stromal tissue also contains blood vessels, as you can see there. So this is a lobule, that's another lobule, this is a lobule, that's another lobule. And we can see the ductal system made up of columnar epithelium surrounding. So these are very low magnification. What you're able to capture there is the lobular anatomy and the trabeculae or the septae. At a high magnification, now focusing on one lobule, we're able to see the parenchymal tissue elements better. And important to note is that we see some ductal system within the lobule. So these are intralobular ductal system. They are intralobular ducts, as opposed to the extralobular ducts that we've just seen in the previous image, which are this one. So this is extralobular, but these are intralobular. Remember, extralobular means outside the lobule, which means within the connective tissue framework, and intralobular means within the lobule, and usually this is smaller ones. So here we are seeing intralobular ducts. But in addition to that, we're also seeing the acini. And at this magnification, we're able to see two different types of acini. The acini which are serous, the ones which are deeply staining, and the acini which are lightly staining, these are the mucus acini. So the mucus acini and the serous acini. So we can conclude something very important about the submandibular gland, that it's a mixed acini gland. It has both mucus acini and serous acini. Remember, in the parotid, what we saw was that the gland was predominantly of serous acini. Now in submandibular gland, we are saying the parenchyma is of mixed acini, both serous and mucus acini. A higher magnification of the acini displays something quite important also to note about the submandibular gland. In some regions, we see a cup of the serous acini covering the mucus acini. And this is what we call the serous demilion. So we see the serous demilion there. This is a serous demilion. That's a serous demilion. Just a crescentric cap of the serous cell over the mucus acini. This is what we call serous demilion. So very unique for submandibular gland. This is one of the things we see on histological slides of submandibular gland. Okay, now we can talk about the ducts of the submandibular gland. The main duct of the submandibular gland is called the Wharton's duct. This Wharton duct is about 5 to 6 centimeters long and about 1 to 3 millimeters wide. So it's slightly narrower than the parotid gland. It is formed by the union of multiple ductal tributaries from the superficial lobe, actually. So multiple ducts will join to form the submandibular duct, usually behind the mylohyoid muscle there. After the duct has been formed, it usually turns behind the mylohyoid muscle, and that turn is what we call the genu of the Wharton's duct. So this is the genu or the turn. In a celogram image that will be visualized as well. So this is celogram image of the submandibular duct and gland. This is the gland. We can see multiple tributaries joining from the superficial lobe to form the duct. And so this is the genu. And then as the duct runs through the sublingual space together with next to the deep lobe, the duct from the deep lobe also join the duct, as we can see in that particular image. And so the submandibular gland traverses the deep lobe as well as the sublingual space as it runs towards the anterior side near the floor of the mouth. We can see that course there going between the sublingual gland and the muscles of the tongue, the intrinsic muscle of the tongue, as well as the genioglossus muscle, which is an external. We don't see the okay, this is the genioglossus actually. So of the tongue. So the duct is between the two. After that, the duct will come. So it's passing through here, the green one, medial to sublingual gland, then open somewhere there. So that opening is at the floor of the mouth. It will pierce the oral mucosa of the floor of the mouth to drain there just below the tongue on either side of the lingual frenulum. This is the lingual frenulum. And this elevation here is what we call the sublingual fold. This sublingual fold represents the position of the sublingual glands. So we have right and left sublingual gland. Medial to that sublingual fold is this region there, which we call the sublingual papilla. So this sublingual papilla, at the summit of that sublingual papilla is where the submandibular glands do open. They empty at that point. All right, so that is Wharton's duct or the submandibular duct. And that summarizes the story of the submandibular gland. We can now talk about the sublingual salivary gland in terms of its location. Actually, the smallest of the three salivary glands that we've talked about now. This particular gland lies between mylohyoid muscle, which is this one, and the mucosa of the oral cavity, which is that one. It's just below the tongue, and that's why it's called sublingual. It creates the impression on the floor of the mouth that I've already shown you, the sublingual fold. Now, let's talk about the ducts of the sublingual gland. The ducts of the sublingual gland are multiple. There are about 8 to 20 excretory ducts which drain the gland. And from the posterior side, most of the glands will drain independently onto the summit of the sublingual fold. So on that sublingual fold, you'll have independent opening of the excretory ducts of the sublingual gland opening. And this applies to the most posterior parts generally. A few ducts, and especially the ones in front, will drain directly into the submandibular duct. Occasionally, we may have a major sublingual duct, which is also called the Bartholin's duct. When present, it will drain the anterior gland. So it's not always there, but may be present. When present, it drains the anterior part of the gland. And this is occasionally seen in salogram because that opening of the sublingual gland, or rather the duct of sublingual gland, that major duct of sublingual gland opens together with the duct of the submandibular gland, which we call the submandibular duct. So when a contrast is put through the sublingual papilla, it will opacify both the submandibular duct as well as the duct of the sublingual gland. So in this image, this is the duct of the sublingual gland, which we call the Bartholin's duct. And this is the duct of the submandibular gland, which we call the Wharton's duct. Let's talk about the relation anatomy of the sublingual gland. Having mentioned that it lies between mylohyoid muscle below and mucosa of the oral cavity above, what are its relations? So inferiorly, the muscle mylohyoid, and superiorly, the mucosa of the oral cavity. Laterally, we talk about the medial border of the mandibular body, and this will be an impression made by the gland, which we call now the sublingual fossa. Distinguish that from the submandibular fossa. They'll be separated by the mylohyoid line on the medial aspect of the anterior body of the mandible. Now, on the medial aspect of the gland, what do you have? There are a number of structures which will be on the medial aspect, depending on at which level, but we have genioglossus muscle, we have hyoglossus muscle, we have the submandibular duct, we have the lingual nerve. In this image, we see the hyoglossus muscle, submandibular duct, lingual nerve. Here the vessels are there, a bit lower though. So that is the medial relation of the sublingual gland. In terms of neurovascular supply, the only thing I want to mention is that sublingual branches of the lingual artery supplies the gland, and submental artery branch of facial artery also supplies the gland. So those are the arterial system. Branches of lingual artery eventually, and branches of facial artery. In terms of innervation, the secretomotor innervation is similar to that one of the submandibular gland, postganglionic fibers from the submandibular ganglion, and you remember the long pathway. The vasomotor innervation will also be similar to that one of submandibular gland, superior cervical ganglion. The genosensory will also be similar to that of the submandibular gland. We have fibers of lingual nerve supplying the gland. So this image shows you the position of the submandibular ganglion. We already mentioned this, and this shows you the lingual nerve also. You see fibers going to the sublingual gland as well. Histologically, now what is it that we want you to capture? Histologically, the unique thing about the sublingual gland is the fact that its acini are predominantly mucus, as we can see in this particular field. So the other concepts of description of salivary gland notwithstanding, the most unique thing that distinguishes sublingual gland from the other glands histologically is the fact that the acini are predominantly mucus, as we can see in this particular image. So it has predominantly mucus acini. All right, that is the story of the sublingual gland. We can now talk about the suprahyoid neck spaces. We'll name them, and we'll also talk about the contents of each space. So just to mention in context, when you talk about suprahyoid neck, we are talking about the region of the neck between the hyoid bone and the base of skull. There are many spaces in the suprahyoid neck indeed. Let me just mention them in this list first. We have the submandibular space, which is also connected with the sublingual space and the submental space. This image, that's the submandibular space. This is the this is the sublingual space. And we are not seeing the submental space in this particular section because there's a section at the level of the floor of the mouth. So the submental space is a bit inferior to this level. Those three spaces, I've mentioned them together because they could be continuous. Then we have what we call the masticator space, which is this one. Masticator space is quite extensive indeed. This just captures a lower section of it, but it extends much up, as we're going to see, and so it might be, in some sections, it'll be much bigger than this one. The masticator space is continuous with another space that usually runs here, which we call the buccal space. Again, we'll talk about it more. The buccal space will be more dominant at a higher level than this region. Then you have the parotid space. The parotid space is the space that contains the parotid gland. We have the parapharyngeal space, also known as the pre-styloid parapharyngeal space, or you can just call it the parapharyngeal space. That is the parapharyngeal space. It is somewhat the center of the other spaces if you look at only one side. Then you have the pharyngeal mucosal space. The pharyngeal mucosal space is the region around the pharynx, basically. And so this is the center of all the spaces. If you look at both sides, it's the deepest space. Then you have the retropharyngeal space. The retropharyngeal space is the region just behind the pharynx, that one. We had already talked about the retropharyngeal space when we discussed the infrahyoid neck spaces, so we will not discuss this one in this particular lecture. But remember that the space that is behind the pharynx and continues all the way from base of skull to even the upper part of the mediastinum. Its boundaries would be the visceral fascia anteriorly and the alar fascia posteriorly. Then behind that is the danger space. Danger space also extends from the base of skull all the way to the mediastinum. And it's called danger space because it's quite extensive. It can go all the way to the posterior mediastinum. The boundaries are the alar fascia in front and the prevertebral fascia behind. We will not talk about those spaces, because we discussed them in the infrahyoid neck spaces. We also have the carotid space, which is this one, surrounded by the carotid sheath, also extending both suprahyoid and infrahyoid neck. Again, we'll not discuss it. Remember, it contains the common carotid artery, internal jugular vein, the internal carotid artery, and now in the suprahyoid neck, it will also have the vagus nerve, glossopharyngeal nerve, the cranial accessory nerve, a hypoglossal nerve at some point. Out of all those nerves, the one that extends to the infrahyoid neck is the vagus nerve only. The posterior cervical space is this one here. Posterior cervical space is a space that we see almost equated with the posterior tongue of the neck generally. Again, it traverses both spaces, but much of it is in the infrahyoid neck. And lastly, the perivertebral spaces. Perivertebral spaces continues throughout, divided into two. We have the prevertebral compartment of the perivertebral space and the paraspinal compartment of the prevertebral space. Remember, these two are continuous throughout. So again, both in the suprahyoid and the infrahyoid neck. So in a nutshell, the one we are going to discuss in this particular lecture, the first 5 there. The last 4, the ones in green, are both suprahyoid as well as infrahyoid spaces. We've already discussed them in the previous lecture, so we will not discuss them here. The ones in blue are new, and we are going to talk about them in this particular lecture. This image captures for us, it's a CT image of the suprahyoid neck, generally at the level of the mandible. As you can see, this is the mandible. And so we see the different spaces. The masticator space is there. We have the parotid space there. This is the carotid space. That is the parapharyngeal space. The pharyngeal mucosal space is somewhere here. And of course, the spaces which will continue from up down, you can also see them here. The danger space, the retropharyngeal space, the prevertebral space, the paraspinal space, you can see them there. And posterior cervical space, you can also see there. Maybe this image will also be important to try to compare the two. That is the infrahyoid neck spaces on your left and suprahyoid neck spaces on your right. Important to note that there are some spaces like the visceral space in the infrahyoid neck that we now don't talk about at this particular point. The equivalent of it is the pharyngeal mucosal space that we'll talk about. But there are other spaces which are both in the infrahyoid as well as suprahyoid, and actually many of them. Retropharyngeal space, you can see it here as well as there. Danger space, you can see it there as well as there. Parotid space, which is this region here, you can see it there. The posterior cervical space, which is this region, you can see it there. Now, I want us to talk about the suprahyoid neck spaces. Let's begin with the submandibular space. The submandibular space, as the name suggests, is the space below the mandible. Generally, this is a space centered around the submandibular triangle. So its key content will be commensurate with the contents of the submandibular triangle. Remember them: superficial lobe of the submandibular gland, the submandibular group of cervical lymph nodes, the facial artery as well as facial vein. The inferior loop of the hypoglossal nerve crosses in this particular space. Of course, we do have fat tissue as well. Important to note is that the submandibular space communicates freely with both the sublingual space as well as the submental space. So this is still the submandibular space, and this is the submental space. There are some authorities that have a different view regarding submandibular and sublingual space. They consider the sublingual space as a subcompartment of the submandibular space, and it's understandable because we are saying that the two are continuous, usually behind the mylohyoid muscle there, where the submandibular gland actually also turns. There's a free continuation there because there's no capsule covering. So there are spaces which are continuous. And so some authority consider them the one. In this particular lecture, we consider them as different. Most authorities do so as well. So this is a MRI scan at the level of the floor of the mouth, extending from the hyoid bone, the one you're seeing there. Going up, I want to use this to show you the submandibular space. So it's scanning, going up now, that the submandibular space, we're now at the level of the mandible. We can see the submandibular space up to there. Okay, the next space to talk about is the sublingual space. This is the sublingual space. The sublingual space is just below the tongue. And so it's part of the floor of the mouth generally. In this image, that's the sublingual space. Posteriorly, as we mentioned, sublingual space will continue or communicate with the submandibular space. And for that reason that some people consider them as one. Well, the sublingual space also communicate with each other. The right and the left sublingual space communicate with each other through a narrow region just below the frenulum of the tongue. The key contents of the sublingual space are the sublingual gland and its ductal system. We talked about 8 to 20 excretory ducts, and you may have a major sublingual duct of Bartholin. We have the deep portion of the submandibular gland. Remember, that's the deep lobe of the submandibular gland, as well as the Wharton's duct, which is the duct of the submandibular gland. Lingual artery, vein, and nerve also pass through the sublingual space. Glossopharyngeal nerve enters the space from behind. Hypoglossal nerve enters the space from below after looping through the submandibular space. Those are the key contents of the sublingual space. That is still the space. So distinguish sublingual from submandibular in this particular image. I want to show you again through a scanned image MRI at the floor of the mouth so that you can see the sublingual space. So extending from submandibular, this is the sublingual space now, region below the tongue. The third space to talk about is the submental space. The submental space is the space within the submental triangle in this particular region. This space is communicating freely with the submandibular space because we don't have a fascial covering there. It's only the anterior belodigastric, so it's not limiting. The key contents, as we had mentioned, origin of the anterior jugular vein and submental group of cervical lymph nodes, which is termed level 1A of cervical lymph nodes. The other space to talk about is the masticator space, a very big space in the suprahyoid neck. We'll spend more time here. So the masticator space is located on either side of the face, anterior to the parotid region. there'll be this region corresponding with the angle and ramus of the mandible, as well as the posterior body of the mandible. This masticator space is enveloped by the investing fascia of the neck. The investing fascia of the neck splits into two lamina to enclose the masticator space. The superficial lamina of the investing fascia will attach around the zygomatic arc, but some fibers extend even over it to the temporal fascia. The deep lamina will attach to the pterygoid plate as well as the basal skull. And so it encloses the muscles of mastication, and that's why it's called the masticator space. It also encloses the foramen ovale and the mandibular nerve within there. This masticator space can be viewed to have some 4 compartments, but 2 of them are the most important, but we'll talk about 4 of them. We have the temporal fossa, which is above the level of the zygomatic arc. So it's also called the suprazygomatic compartment. We have the infratemporal fossa, which is below the zygomatic arc. So it's also called the infrazygomatic compartment. But within this infrazygomatic compartment, we may also have the pterygomandibular space. It's generally part of the infratemporal fossa. There's another space that we call the submasseteric space that we'll also talk about. In this particular image, submasseteric space will be somewhere there. And pterygomandibular space will be somewhere here. And then the whole of that is the masticator space. Important to note is that we call it masticator space because it contains muscles of mastication. Their names are the masseter muscle, which is this one, temporalis muscle, which is this, the lateral pterygoid muscle, which is that one, and the medial pterygoid muscle, which is that one. Those are muscles of first pharyngeal arc origin. Now let's talk about those 4 spaces of the masticator space. We start with the temporal fossa. The highlighted region represents the temporal fossa. It is important to note that the masticator space extends much higher up to the level of the temporal lines of the parietal bone. And so when we're investigating any pathology within the masticator space, we must investigate, we must check even much higher. As you can see, it is above the zygomatic arc, and so we call the suprazygomatic compartment of the masticator space. This compartment communicates freely with the infratemporal fossa, medial to the zygomatic arc. Usually, there's a free communication. Actually, the muscle temporalis also passes through that gap. This image shows you the temporal fossa, and we can, in this particular image, even now understand the osseous floor of the temporal fossa. We have the squamous part of the temporal bone. We also have the greater wing of sphenoid. We have some part of the frontal bone, and the parietal plate is also there. The 4 bones meet at this region, what we call the pterion. So the pterion is part of that temporal fossa. This region primarily contains temporalis muscle. Temporalis muscle is one of the muscles of mastication. It usually originates from the temporal fossa and insert onto the coronoid process of the mandible there. So its action will be to close the mouth. Mandibular elevation closes the mouth. So that's temporalis is one of the muscles of mastication. Apart from temporalis, there are also other contents of the temporal fossa. So you have the superficial temporal artery, which is a branch of the external carotid artery, as you can see there. So this is the superficial temporal artery, a branch of the external carotid. Usually it has this frontal and posterior branch. We also have the deep temporal neurovascular structures. So the deep temporal neurovascular structures refer to the deep temporal nerves and the deep temporal arteries. The nerves are from mandibular division of trigeminal, and the arteries are from maxillary artery. And they're called deep because they enter the muscle from medial aspect, the deep aspect. So these are the deep temporal neurovascular structures. Usually we have an anterior and a posterior one. Then we have the zygomaticotemporal nerve. Zygomaticotemporal nerve is a branch of the zygomatic nerve, which is a branch of the maxillary nerve. It also traverses the temporal fossa. Occasionally, we can talk about the temporal fossa as having superficial and deep temporal spaces, as the name suggests, with respect to the muscle. Okay. Beyond that, we can now talk about the infratemporal fossa, which is the infrazygomatic compartment of the masticator space. So it's located below the zygomatic arc, or we can talk about at that level. In terms of its boundaries, we can talk about the ramus of the mandible being a lateral boundary. So the space is inside, it's medial to this one. The ramus of the mandible is a lateral boundary. The posterior boundary will be the styloid process and the external auditory meatus of the bone forming it. That's the tympanic bone. Superiorly, we have the inferior surface of the greater wing of sphenoid bone, which is this one. So the inferior surface of that one. Well, the other lateral thing would be the zygomatic arc. In addition to the ramus of the mandible, the zygomatic arc is also lateral, as you can see. And then on the middle aspect, we'll expect the lateral pterygoid plate being on the middle aspect. Then anteriorly, we have the posterior wall of the maxillary bone. Maybe this image captures that. With the ramus of the mandible removed, we can see the lateral pterygoid plate forming a medial boundary. And we can see the posterior surface of maxilla forming the anterior boundary. I believe the others, we've understood them. The inferior surface of the greater wing of sphenoid forming the superior boundary or the roof. The external auditory meatus and its bone, as well as the styloid process being posterior. So the inferior boundary will be the plane corresponding with the superior border of the body of the mandible. The infratemporal fossa communicates with a number of spaces through various channels. We can talk about them. It communicates the orbit through the inferior orbital fissure. Remember, there are some structures that pass through that particular route. It communicates with the pterygopalatine fossa through the pterygopalatine fissure as well. This will be the passage of the maxillary artery. Superiorly, it communicates the temporal fossa. This will be superiorly and lateral. This will be the passage of the temporalis muscle together with the deep temporal neurovascular structures. And superiorly and medially, it communicates the middle cranial fossa through foramen ovale as well as foramen spinosum. In foramen spinosum, we'll have passage of the middle meningeal artery and nervus spinosum. And in foramen ovale, we have passage of the mandibular nerve, accessory meningeal artery, lesser petrosal nerve, as well as the animesary vein connecting pterygoid venous plexus to the cavernous sinus. So those are the communications of the infratemporal fossa with the surrounding spaces. What are the key contents of the infratemporal fossa? Infratemporal fossa houses the following. It houses the medial and the lateral pterygoid musculature. So the medial pterygoid muscle inserts onto the angle of the mandible medially. Its contraction will cause closing of the mouth. It elevates the mandible. The lateral pterygoid muscle, on the other hand, inserts onto the condylar process and also the neck of the condylar process, the condyle itself and the neck, as well as some capsule there, or rather disc there. The lateral pterygoid muscle inserts there, and so its contraction will pull the condylar process of the mandible anteriorly. That makes a unique movement of the mandible. It will make the mandible to open. Basically, it will make the mandible to go down, which means you open the mouth. So lateral pterygoid muscle opens the mouth. If you notice, we talked about the temporalis muscle closing the mouth. We've talked about medial pterygoid muscle closing the mouth. The other muscle we've not talked about, but we can talk about, is masseter muscle that usually attaches on the zygomatic arc to the lateral surface of the angle of the mandible. That one also closes the mouth, a very strong muscle actually that closes the mouth. So those three close the mouth. We are now mentioning a muscle of mastication that opens the mouth. That's the lateral pterygoid muscle. So while the other three muscles of mastication, medial pterygoid, temporalis, and masseter, close the mouth, the lateral pterygoid muscle opens the mouth. This muscle has two parts. There is an inferior portion or a lower portion and an upper portion. We'll talk more about it when we discuss muscles of mastication. Apart from the medial lateral pterygoid muscles, we also have the maxillary artery and some of its branches, and there are quite many branches. We also have the mandibular nerve and its branches. So the mandibular nerve branches are here. This is one, the lingual nerve. That's another one, inferior alveolar nerve. This is another one, buccal nerve. We are going to see that in another slide. The branches of the maxillary artery are quite many here. You can see them. We'll talk more about them when we focus on maxillary artery. This image now captures for you the mandibular nerve and its branches. So other than the buccal nerve, lingual nerve, inferior alveolar nerve, we can also see other nerves, auriculotemporal nerve there, the deep temporal nerves there. In addition to that, we also have the coda tympani nerve, which is this one. So remember, coda tympani nerve is the facial nerve contribution to the lingual nerve. So it will pass through like that to join lingual nerve at that point. And this will be part of what will give us taste fibers in the anterior part of the tongue, as well as preganglionic parasympathetic fibers to the submandibular ganglion. We have the lesser petrosal nerve nodes shown in this particular image, but remember it enters through foramen ovale and synapses in a ganglion there, which we call the otic ganglion, from which the postganglionic fibers join auriculotemporal nerve to reach the parotid gland. Lastly, we have the maxillary vein. That will be a short vein in this particular region. And extensively, we have the pterygoid plexus of veins that are usually between the muscles. So those are the key contents of the infratemporal fossa. We can now talk about the pterygomandibular space. Pterygomandibular space is just a small compartment of the infratemporal fossa, the interface between the mandible itself and the pterygoid muscles. That interface contains maxillary artery and some of its branches also contain the inferior alveolar nerve. It has the lingual nerve. So this is the maxillary artery. This is the lingual nerve, that's the inferior alveolar nerve. So you can see the muscles, the pterygoid muscles there. And so these structures between the mandible, which has been removed, and the muscles is what we call the pterygomandibular space. The buccal nerve is also there, which is this one. Or that one, that's a buccal nerve. We can see it clearly there. Nerve to mylohaloid is this one. It's a branch of the inferior alveolar nerve. We also sit in that particular space. And pterygoid venous plexus, which I've told you is also present between the muscles and also between muscles and the mandible. So it's just a small part of the infratemporal fossa. This is the pterygoid venous plexus, as you can see. Then we have the submasseteric space. So the submasseteric space is the space between the ramus of the mandible and the masseter. It's a potential space. We've already talked about masseter muscle, the muscle of mastication that closes the mouth, arises from the zygomatic arc to the angle of the mandible laterally. We call the submasseteric space the masseteric space. Of important why it mentioned is because of possible site of spread of infection that may come from either the mandibular molar teeth, or if you have a fracture of the mandible, infections from that fracture may also go into this particular space. Right, so that summarizes the masticator space. We can now talk about the buccal space, which we also call the buccinator space. The buccal space is also continuous with the masticator space. Actually, and some people look at them together, but we'll consider them separate in this particular context. It's a fat-containing space located on either side of our cheeks. Actually, is the one that forms a cheek fat pad. So in this particular region, this is the buccal space. Distinguish that from the masticator space. The buccal space lies between the muscle buccinator, which is this one, a muscle of the second pharyngeal arc origin, and a platysma muscle. Platysma muscle in the subcutaneous tissues of the face, somewhere here. So this is the buccinator space. This space communicates freely with the masticator space, and that's why some people consider them as one continuum. What are the key contents? So fat is the main content. The cheek fat pad is the main content, but also in this particular region, we have the parotid duct that crosses the space. We also have or may have the accessory parotid gland if present. We may have the facial and buccal arteries and vein also traverse in this particular space. We can see facial vein in this particular one. The buccal branch of the facial nerve also traverses this space as it goes to the buccinator muscle. And then buccal nerve, which is a branch of the mandibular nerve, also traverses this space as it goes to the skin around this region. These are the contents of the buccal space, which is also known as the buccinator space. I have an MRI image to demonstrate the buccal space, and what is important is for you to distinguish it from the masticator space, which is this one. So this is the buccal space, this is the masticator space. I'll play that scanned image. So you can see that one. Okay, so that is the buccal space, and sorry about the other voice in the background. All right. We can now talk about the parotid space. The parotid space, which is this one, is a pyramidal space on the lateral side of the face that contains the parotid gland. So pyramidal because we can see the base is superficial there and the apex is medial there. This space is also enveloped by the investing layer of the deep cervical fascia, as we already talked about when we looked at parotid gland. So the key content of this space will be the parotid gland itself, the intraparotid lymph nodes, as well as the lymphatic vessels within there. Facial nerve, remember the facial nerve enters the parotid gland and ramifies into maybe defined 5 branches. So that happens within the parotid gland, and so it's part of the parotid space. The external carotid artery that runs through and gives us the superficial temple, as well as the maxillary artery, also divides in this particular space. And the vein that accompanies the external carotid artery, the retromandibular vein, is also a component of the parotid space. This image will show us that particular anatomy. So this is the parotid space. Scanning through up and down, up and down. And so we hold it there. Don't confuse it with the masticator space or with the buccal space or with the carotid space, that one, or with the parapharyngeal space, that one. Okay, that brings me then to the parapharyngeal space. The parapharyngeal space is a very important space clinically. It's an inverted pyramidal space that is filled with fat tissue, this one. It extends from the petrous bone, and that will be the base of the pyramid, to the level of the lesser horn of the hide bone, and that will be the apex. Radiologically, in CT scan, this is how it looks like. This hypodense space, when you say hypodense, means it's darker in CT. So this kind of density is the one consistent with fat density. Compare that with the fat here as well. So this is the fat in the buccal space. And this is now air. It's much darker than fat, if you can clearly see that. So we are comparing the density here of fat and the density here of fat. This is different from here, which is air. This is now fat. So this fat density and that fat density is what represents what we call the parapharyngeal space. The spaces are occupied with fat tissue. Well, apart from fat tissue, you may have other structures. For example, the ascending pharyngeal artery may pass through this particular space in some situation. Occasionally, if you have some rests of the salivary glands, they may also occupy this particular space. But remember, those are ectopic salivary gland tissue that occupy this space. So usually the main content of this space is fat. Important to note is that this parapharyngeal space is relatively central if you look at the spaces for one side. It's relatively central. It is surrounded by a number of suprahyoid spaces. Look at that one. So this is the parapharyngeal space. It is surrounded by the masticator space anterolaterally, parotid space posterolaterally, carotid space posteriorly, the prevertebral space posteromedially, and the pharyngeal mucosal space anteromedially. So it's surrounded by several spaces. That's the story. Now, why are we mentioning that one? This is of clinical importance because if there is a mass pathology in those spaces that I've mentioned, there's a likelihood of the parapharyngeal fat being displaced away from the mass. And so we can use that direction of displacement of the parapharyngeal fat to help us understand or know or determine the site of origin of a particular mass. For example, if you have a mass in the carotid space, it will displace the parapharyngeal fat anteriorly. If you have fat in the parotid space, if you have a mass in the parotid space, it will displace the parapharyngeal fat anteromedially. But if you have mass in the pharyngeal mucosal space, which is this one, it will displace this particular fat posterolaterally. A mass in the masticator space will displace this fat posteromedially. The fat will move away from the site of the mass, as shown in these particular images. So this is a mass in the parotid space, displace it that direction. A mass in the pharyngeal mucosal space, displace the fat in that direction. A mass in the carotid space, displace the fat anteriorly. And a mass in the masticator space, displace the fat posteromedially. We can pick that radiologically and so help us to determine the site of a mass. We'll then talk about the pharyngeal mucosal space. The pharyngeal mucosal space is not an actual space, really. It's a space in quotes. But the deepest compartment of the suprahyoid neck spaces, the deepest because the one closest to the airway. In particular, it's closest to the pharynx. It is actually circumscribed by the visceral fascia, which is the mid layer of the deep cervical fascia. Remember, the mid layer of the deep cervical fascia is also termed the pretracheal fascia. So in terms of the location of the space between the pretracheal fascia and the mucosal surface of the pharynx. This space extends all the way from the base of the skull to the level of the cricoid cartilage. And so with that, we understand that it will be continuous with the visceral space of the infrahyoid neck. Remember, the visceral space of the infrahyoid neck houses the trachea, esophagus, the larynx, and the hypopharynx. They are part of that. So this space is continuous. The unique thing about the visceral surface is that when the pretracheal fascia goes suprahyoid, there's a particular way in which it turns that will limit it just around the pharynx, basically. So the key contents of the pharyngeal mucosal space with the pharyngeal mucosa predominantly formed of stratified squamous non-keratinized epithelium. There's also lymphoid tissue deep to that epithelium, and importantly, the lymphoid tissue that's there, examples would be part of what we call the Walde's ring. We'll talk more about it when you look at the pharyngeal anatomy. But this Walde's ring is a ring of lymphoid tissue around the pharynx, and one of them is called the adenoidal tissue, which is found in the nasopharyngeal roof. The eustachian tube traverses the space, and so it's also a content of the space because it connects the nasopharynx to the middle ear. So this image will show us the pharyngeal mucosal space. As we can see, that is part of the extension to the middle ear. It's now scanning through. So that is pharyngeal mucosal space. Just we are focusing on the mucosa of the pharynx all the way from base of skull up to the level of the hide bone down, as you can see there. Some people may consider the pharyngeal mucosal space to extend all the way to the nasal mucosa and oral mucosa, but most authorities do not recognize that. So this is the summary of the suprahyoid neck spaces. We've gone through them. To your left is it's a CT scan image at the level of the floor of the mouth. And that is why we are able to see the mandible there, as well as the sublingual space there. So that sublingual space, this is the submandibular space. The masticator space at this level is quite small, just showing us the level of the masseter because we are much lower. But if you go higher, the masticator space becomes really big, as you can see in this particular image there. Posteriorly, that's the parotid space that contains the parotid gland. And this is the carotid space that has the carotid sheath. This is the parapharyngeal fat space that is centered around the space one side. That's the pharyngeal mucosal space that contains the pharyngeal mucosa. Behind that one is the retropharyngeal space, which is both supra as well as infrared space. And the danger space, again, which is both supra as well as infrared space. Of course, carotid space also in both supra as well as infrared space. And behind that, the prevertebral space with both anterior as well as posterior compartments. Posterior compartment is the paraspinal space, and the anterior compartment is the prevertebral space. For that, the posterior cervical space as well. So the image to your right is an MRI image of the neck spaces. I'll allow it to play as we see the neck spaces. Starting there with the masticator space. The image is now playing. We can now introduce the buccal space there. We've also introduced the carotid space there. We can see some part of the prevertebral space and the paraspinal space in that particular level. The danger space is also at that particular level, and the retropharyngeal space. Now going down, we see the pharyngeal mucosal space and its extension through the eustachian tube. The other space is now becoming slightly bigger. We're scanning much down. We can now see the parapharyngeal space as well, becoming big. We can see the parotid space there. We can now see also the buccal space coming into sight. Notice that the masticator space is still continuous, so quite extensive from up down. We can also see at this particular level the posterior cervical space going down. It's becoming bigger as we move down. At this level, we started to see the sublingual space as well, below the tongue. Some spaces are now diminishing, like the masticator has disappeared, but okay, almost disappearing, but now we see the submandibular space, they are quite expansed. Parotid has now disappeared. So we are now moving slightly down below the mandible. This is now quite below at the level of the larynx now. So the spaces that we are expecting to see beyond here down will be infrahyoid neck spaces as opposed to suprahyoid neck spaces. We can still see them there. So this is the visceral space basically that has now come into play. And that's the carotid space. We are now at the thoracic inlet and upper mediastinum. The reason why we told you that danger space because it continues all the way to the mediastinum. Right, so Having said that, we can now look at the last agenda, which talk about the major neurovascular structures of the suprahyoid neck. We can start the vessels. The vessels will start with the arteries. So the arteries in the suprahyoid neck are the internal carotid artery, which does not give us any branch in the neck. But it's important to remember that the internal carotid artery has multiple segments. Segment 1 is what we call the cervical segment in the neck. It disappears through the carotid canal to go intracranially. As it runs through, it is part of the carotid sheath. The external carotid artery is in the suprahyoid neck, and many branches of the external carotid artery are part of the suprahyoid neck. Some of these branches, the occipital artery goes to the posterior scalp. Posterior auricular artery also goes to the posterior scalp. So these ones are posterior branches of the external carotid artery. They go to the posterior scalp. Lingual artery is the second anterior branch of the external carotid artery. It goes to the tongue. I have highlighted it in green because we are going to talk about this particular artery in the suprahyoid neck in great detail. We also have the third anterior branch of the external carotid artery being the facial artery. We will not talk about facial artery in this particular lecture because we already talked about it when we looked at the anatomy of the face and scalp. So we talked about facial artery in great length in that particular lecture. Remember that the other anterior branch of the external carotid artery, the superior thyroid artery, we are not mentioning it here because it's largely in the infrahyoid neck as opposed to suprahyoid neck. The ascending pharyngeal artery is the medial branch of the external carotid artery. It runs through, or it may run through the parapharyngeal space and supply a number of structures in the pharynx or related to the pharynx in the deep neck generally. We'll not talk about it much because it's a very minor artery. Maxillary artery is a very major artery, and we'll talk about it. It's one of the terminal branches of the external carotid artery. And lastly, superficial temporal artery is also a terminal branch. We'll not talk about it because we already talked about it when we looked at the anatomy of the scalp. So let's focus on these two, lingual and maxillary artery. We start with the lingual artery, called so because it goes to the tongue. The second branch of the external carotid artery and the chief source of blood supply, both to the tongue as well as the floor of the mouth. The lingual artery can be considered to have three parts based on its relationship with the hyoglossus muscle. So if this is the external carotid, this is the superior thyroid, that second anterior branch is the lingual artery. As we can see, once the lingual artery has been given off from the external carotid, it passes medial to the hyoglossus muscle. So the segments would be the region before that posterior border of hyoglossus, that is part 1 or segment 1 of lingual artery. Then the region medial to hyoglossus muscle is the second part. And then the region beyond the anterior border of hyoglossus will be the third part of the lingual artery. This image captures that. So this is lingual artery, segment 1 or part 1, then part 2, and then part 3. As you can see, the artery is quite tortuous in some segments. This is to accommodate the high mobility of the neck and high mobility of the tongue. So you need the artery to accommodate those mobility. What are the branches of the lingual artery? The first part of the lingual artery gives us this branch, which we call the suprahyoid artery. It goes above the hyoid, supply the structure around there. The second part of the lingual artery gives us the dorsolingual arteries, which are multiple. So as you can see in that particular image, those are dorsolingual arteries supplying, as the name suggests, dorsum of the tongue, of course, plus other structures. Then we have the sublingual artery, which is this one. As the name suggests, it goes below the tongue and anteriorly supplies the sublingual gland and much of the floor of the mouth through multiple branches, as we can see there. And lastly, we have the deep lingual artery, which is a terminal branch of the lingual artery. So this one enters the tongue from the deep surface of the anterior tongue and supplies much of the tongue as well. Arteria profunda linguae is basically the deep lingual artery. So that is the story regarding the lingual artery. Remember the branches from each of the segments. The sublingual branch and the arteria profunda linguae are branches of the third part, and basically terminal branches. The other artery to talk about is the maxillary artery, quite an extensive artery, but let's talk about it. It's the larger branch of the terminal branches of the external carotid artery, and the maxillary artery is given off within the parotid gland. So it's initially within the substance of the parotid gland. After that, it enters the infratemporal fossa, just medial to, it passes medial to the mandibular ramus, and then enters the infratemporal fossa. It will traverse the infratemporal fossa and exit the infratemporal fossa through what we call the pterygomaxillary fissure, through which the artery will enter into the pterygopalatine fossa, where it will terminate. As it passes through, the maxillary artery has many branches, over 15 branches, which are named that the artery actually has. These branches will supply both the deep structures as well as some superficial structures. We can describe the anatomy of the maxillary artery into three segments. We have the first part, also known as the mandibular segment, the second part, also known as the pterygoid segment, and the third part, also known as the pterygopalatine segment. Let's approach it in that way so that we are able to understand these many branches. Let's begin with the first part of the maxillary artery. So the first part of the maxillary artery, which we are calling the mandibular part, refers to the part that comes off from the external carotid artery and passes medial to the mandibular ramus. So once it's been given, it just passes medial to the mandibular ramus as it enters the infratemporal fossa before it reaches the muscles, the pterygoid muscles generally. So yes, this part will be partly already within the infratemporal fossa, but not quite between the pterygoid muscles. So that's what we call the first part, the part before the pterygoid musculature. That first part is the mandibular part. This part has 5 branches which are named. And what is unique about the branches from the first part of the maxillary artery is that they go through various foramina in the bones around. So let's name them and also try to name the foramina that they go through. We can see the 5 branches from the first part already here. Middle meningeal, deep auricular, anterior tympanic, inferior alveolar, and accessory meningeal. Maybe as we do this, try to imagine which foramina do each of these arteries traverse. I can help you with that. So deep auricular artery usually pierce the osseous or the cartilaginous part of the external auditory meatus. It just pierces through, and it supplies the external auditory meatus, so the mucosa, as well as the outer surface of the tympanic membrane. The anterior tympanic artery passes through the petrotympanic fissure to enter the middle ear. So this one enters the middle ear, it supplies the mucosa of the middle ear and even the medial surface of the tympanic membrane. So those two arteries are there, the deep auricular and the anterior tympanic, and I've already told you where they go through. Middle meningeal artery passes through the foramen spinosum to enter the middle cranial fossa. So it supplies the middle cranial dura, and actually the middle meningeal artery is the main source of blood supply to the meninges of the cranium. Accessory meningeal artery passes through foramen ovale together with the mandibular nerve, and this artery supplies also the meninges of the middle cranial dura. Finally, we have the inferior alveolar artery. The inferior alveolar artery descends and passes through the mandibular foramen. So it runs through the mandibular foramen or the mandibular canal. It gives several branches to the teeth. They are called the dental branches. And then finally, the artery will come out through the mental foramen as the mental artery. This is the terminal branch. Before it enters the mandibular foramen, it gives rise to the mylohyoid artery that runs to the nerve to mylohyoid. So those are the 5 branches from the first part of the maxillary artery. Remember, the branches from the first part pass through various foraminal fissures of the skull. Now we can talk about the second part of the maxillary artery. The second part is what we are calling the pterygoid part. So understand that once the maxillary artery has entered the infratemporal fossa, it will first give you those branches on the first part. Then there'll be a part where now the maxillary artery is at the level of the pterygoid musculature, and especially its relationship with the lateral pterygoid muscle. So it begins the edge of the lateral pterygoid muscle. We call that the pterygoid part of the artery. The pterygoid part of the artery traverses the infratemporal fossa, either superficial or deep to the lower head of the lateral pterygoid muscle. So occasionally it may be deep, sometimes it may be superficial. This is the lower head of the lateral pterygoid muscle. So in this particular case, this artery was superficial. It gives 5 branches, and these 5 branches given in this second part go to soft tissues, and the soft tissues here are basically muscular tissues. So we do have the deep temporal arteries, which are 2. We have anterior and posterior deep temporal arteries. So we can see the anterior deep temporal artery there, and we can see the posterior deep temporal artery there. The others are the posterior deep temporal nerve and anterior deep temporal nerve. The nerves are from mandibular nerve, anterior division. The arteries are from the maxillary artery. So those are 2 deep temporal arteries. Those ones have gone to temporalis muscle. We also see them there. Then you have the pterygoid artery, which go to the pterygoid muscle. So that's why it's called the pterygoid artery, into the pterygoid muscles, especially even medial pterygoid muscle. We have the masseteric artery that supplies the muscle masseter. And finally, we have the buccal branch the buccal artery that goes to the buccinator muscle, which is this one. That's the buccal branch. So branches of the second part supply soft tissues. Remember, I've listed 4 here, but I've said there are 5 because the deep temporal arteries are 2. The anterior and posterior deep temporal artery. This image also captures for you the branches from the first part, the branches from the second part, and the branch of the third part of the maxillary artery. Let's now look at the branches from the third part of the maxillary artery. The third part of the maxillary artery is what we call the pterygopalatine part. This part will be extending from beyond the level of the pterygoid muscle as the artery goes through the pterygomaxillary fissure and also enters the pterygopalatine fossa. So all that is the third part. That means that the third part will begin from the infratemporal fossa beyond. All right. The branches from the third part can be 5 or 6. What is important about them is that they accompany the branches of the maxillary nerve into various foramina. So in this case, we'll also expect some foramina and also some nerves that accompany the arteries. We have the descending palatine branch, which is this one. The descending palatine branch passes through the pterygomaxillary fissure. So this is pterygoid plate. This is maxilla. So this is pterygomaxillary fissure. This descending palatine branch descends and gives you the greater palatine artery as well as the lesser palatine artery. So the greater palatine artery will pass through the greater palatine foramen. The lesser palatine artery will pass through the lesser palatine foramen. We have the posterior superior alveolar branch. This is the other artery. We can see that. So, okay, now let's follow this one. So this is the descending palatine branch. This is the posterior superior alveolar. By that name, posterior superior alveolar, what comes to mind is that supply the alveolar processes of the maxilla, because we are talking about superior. When we talk of superior alveolar, it means the alveoli on the maxilla, because the alveolar of the mandible, the inferior alveoli. Now we are saying posterior superior, which means that the posterior part of the alveolar. So we are focusing on the alveolar processes of perhaps the molar and the premolar teeth. So that is the second branch of the maxillary artery, third part there. The third branch I want to mention is the infraorbital branch. The infraorbital branch will run also with the infraorbital nerve, pass through the infraorbital fissure, which is in the floor of the orbit, and come out finally as the infraorbital artery and nerve, if you look at it from neurovascular point of view. The sphenopalatine branch is that one. Quite a big branch. The sphenopalatine branch is the one that will supply most of the mucosal elements of the nose, both on the septum as well as on the lateral side, on the lateral wall as well as the septum. So most of the mucosal, nasal mucosa is supplied by branches of the sphenopalatine artery. Then you have the pharyngeal branch. The pharyngeal branch goes to the sphenoidal air sinus. Occasionally, you may have the artery of the pterygoid canal. And if you have that one, then we have 6 branches from the third part of maxillary artery. If you exclude it, then you have 5 branches of the third part of maxillary artery. So we have at least 15 branches of the maxillary artery. 5 from each part, we can say so. This is a summary of the branches of the maxillary artery from the first part, second part, and third part. The third part may be 5 or 6. Take note that the branches of the first part will go to various foramina. The branches from the third part also go to some foramina, but importantly also they run with nerves from maxillary nerve. Branches from the second part go to soft tissues. So this image also shows you in a nutshell which foramina are traversed by which artery, so you can take time to just understand that. All right, that is the maxillary artery. Now let's talk about veins in the suprahyoid neck. The veins in the suprahyoid neck will be many, but most of those veins we've already talked about in our previous sessions: the internal jugular, retromandibular vein, superficial temporal vein, facial vein. We've talked about them. And the good thing about veins that mostly they follow arteries as well. But there's a venous system that it's really important to talk about because it may not necessarily follow the pattern of the arteries. This is the pterygoid venous plexus and the maxillary vein. Let's talk about it in this particular text. So pterygoid venous plexus is a plexus of vein that is found largely within the infratemporal fossa, between the muscles of mastication within the infratemporal fossa. You may find between the mandible and the lateral pterygoid, and between the lateral pterygoid and the medial pterygoid. The contribution to the pterygoid venous plexus comes from several veins. If you think about most of the branches of the maxillary artery, the accompanying veins actually drain into the pterygoid venous plexus, most of them. And so it's contributed by many veins. However, in addition to that, it also has some communications, which could be also contributions from the inferior ophthalmic vein. Remember, we discussed that when we looked at the orbital cavity and the eyeball. So that also is an important contribution, and it's a contribution that's also clinically important. The other clinically important communication is the connection between the facial vein and the pterygoid venous plexus through the deep facial vein. And then the other one that is of clinical importance is the communication between pterygoid venous plexus and the cavernous sinus through emissary veins that may pass through foramen valley. Remember, the importance of understanding the communication is because of possibility of spread of infections from the face. Remember the danger area of the face concept, and also between the pterygoid venous plexus and the cavernous sinus. Now, maxillary vein is a very short vein formed from the confluence of the multiple veins from the pterygoid venous plexus. So it's just a short stem that accompanies the first part of the maxillary artery. This maxillary vein joins the superficial temporal vein to form the retromandibular vein. And I believe you remember the story from there, that retromandibular vein divides into 2, anterior division and posterior division. The posterior division joins with the posterior auricular to form external jugular vein. The anterior division joins with the facial vein, and they both drain into the internal jugular vein as the common facial vein. All right, so that's the story of the venous drainage. Now we can finish with the nerves in the suprahyoid neck. When you look at the nerves of the suprahyoid neck, again, there are quite many nerves. Luckily, we've discussed most of them in our previous session, either part 1 or part 2, we've discussed them. But I can mention them here. We have mandibular division of trigeminal nerve. That one we've not discussed, and we'll discuss that one in this particular session. But the ones we've discussed is the 7th cranial nerve, facial nerve. We discussed this when you looked at parotid region and facial nerve. Glossopharyngeal nerve, we've discussed that when we looked at the anterior neck infrahyoid spaces. We discussed glossopharyngeal nerve. We also discussed the vagus nerve. We discussed the accessory nerve in 2 parts, the spinal accessory, when we discussed the posterior neck triangles, and the cranial accessory when we discussed the infrahyoid anterior neck triangles. Hypoglossal nerve we've discussed in the previous session as well, and superior cervical ganglion and its postganglionic sympathetic branches to the head region. We've also discussed them. So if you've forgotten much about them, you can review the previous sessions. But let's dedicate this part, for the sake of time, to discuss the mandibular division of trigeminal nerve. So the mandibular nerve is the largest division of the trigeminal nerve, basically. We can understand it in the context of originally the main thing is within the trigeminal nerve. So if you are to talk about the origin of the mandibular nerve, we'll say it arises from the trigeminal nerve at the level of the trigeminal ganglion, but the nucleus of origin, we'll have to trace that to the trigeminal nerve itself. So trigeminal nerve has 2 nuclei of origin. It has the motor nucleus of trigeminal, which is located within pons. This motor nucleus of trigeminal is a special visceral efferent nucleus, which means it's a brachiomotor nucleus of trigeminal, responsible for innervation of muscles of the first pharyngeal arc. The muscles of the first pharyngeal arc are the muscles of mastication. So they include temporalis, masseter, medial pterygoid, lateral pterygoid. Primarily, those are the muscles of mastication. However, muscles of first pharyngeal arc extend beyond those 4 muscles of mastication. So the other muscles that also come from first pharyngeal arc include the anterior belly of digastric muscle, mylohyoid muscle. We have the tensor veli palatini and the tensor tympani muscle. Those ones are also muscles of the first pharyngeal arc, and they're all innervated from the motor nucleus of trigeminal. Then you have the sensory nucleus of trigeminal. Sensory nucleus of trigeminal is a general somatic afferent nucleus. Quite extensive nucleus in the brainstem, having 3 components: mesencephalic nucleus of trigeminal, chief nucleus of trigeminal, and the spinal nucleus of trigeminal. The chief nucleus of trigeminal is the main nucleus located in the region of pons. This one receives the nerve fibers responsible for touch and pressure sensations. Then we have the spinal nucleus of trigeminal, which receives the sensory nerve fibers responsible for pain and temperature sensations. Important to note is that the spinal nucleus of trigeminal traverses the brainstem, traverses the medulla oblongata up to the level of the 2nd cervical segment of the spinal cord, C2 segment. And so quite extensive. It's also important to note that the nerves that terminate in the spinal nucleus of trigeminal are not all from the trigeminal nerve. Some are from facial nerve, some from glossopharyngeal, some from vagus nerve. They also project to the spinal nucleus of trigeminal because those nerves also have GSA function. The chief nucleus of the mesencephalic nucleus of trigeminal is the nucleus of trigeminal within the midbrain. The unique thing about this nucleus is that it's the one that receives fibers responsible for proprioception. Unlike the other sensory nerves, which usually have their cell bodies outside the central nervous system and the central process entering the brainstem, the proprioceptive fibers of trigeminal nerve, which largely come from muscles of mastication and extraocular muscles, the proprioceptive fibers have their cell bodies within the nucleus, within the brainstem. So that the chief nucleus, the mesencephalic nucleus of trigeminal, beg your pardon, the mesencephalic nucleus of trigeminal contains cell bodies of first order sensory neurons. That's quite unique about the mesencephalic nucleus of trigeminal compared to the other sensory nuclei of trigeminal. Perhaps the only nucleus, sensory nucleus, that contain the cell bodies of first order neurons in the whole central nervous system. Anyway, so these are the nuclei of origin of trigeminal, and so mandibular nerve is within that particular discussion. This is the trigeminal nerve. It comes out at the junction between this is pons, so this is the trigeminal nerve. It's coming out at that particular point between that and the cerebellum at that particular point, within the middle of what we call the middle cerebellar peduncle. That's the trigeminal nerve. So let's talk about its course. As it exits pons, it exits via two routes. There's a big one and a small one. The big one is called the potium major. And this potium major is the sensory root of the trigeminal nerve. And the smaller component is called the potium minor, which is the motor root of the trigeminal nerve. As the nerve exits, it enters through the subarachnoid space around this region. This is the cerebellopontine angle cistern, which is usually located around this particular part. After that, the nerve will pierce the dura mater at the apex of the petrous bone to enter another space, which we call the Merkel's cave or the trigeminal cave. So this shows you the point at which the nerve pierces the dura mater to enter this particular space. The roof has been removed so that you can see the cave, but that's the location, the trigeminal cave, also known as the Merkel's cave. Within this cave, we have the trigeminal ganglion, which is also known as the Gasserian ganglion. So this ganglion is just inferolateral to the cavernous sinus. As you can see, this is the cavernous sinus. It's inferolateral. The ganglion itself is not within the cavernous sinus, but some branches from the ganglion will pass through the cavernous sinus. That is the ophthalmic division of trigeminal and the maxillary division of trigeminal. They pass through the cavernous sinus, or they'll be at least in the lateral wall of the cavernous sinus. The mandibular one does not pass through the lateral wall of the cavernous sinus. This mandibular division will be formed by both, the mandibular nerve itself is formed by both the third division of the sensory division of trigeminal and the motor root of trigeminal. Those two unite together, usually just below the foramen ovale, to form the mandibular nerve. So this image shows you the sensory root and the motor root of the trigeminal nerve. The sensory root is the one related to the ganglion, which we call the Gasserian ganglion, or sometimes called the semilunar ganglion or the trigeminal ganglion. So from that ganglion, there are three divisions: ophthalmic division, maxillary division, and mandibular division. The mandibular division from the ganglion is the one that joins the motor root of trigeminal nerve to form the mandibular nerve. And that union could be achieved finally just below the foramen ovale. So this image shows you the mandibular nerve as it exists through the foramen ovale. Remember, this one does not enter the cavernous sinus, but V1 ophthalmic and V2 maxillary pass through the cavernous sinus at some point. So once the nerve has come out, what happens? Well, it traverses foramen ovale together with other structures. The easier way of remembering the structure that passed through foramen ovale is to say MEL, M for the mandibular division or trigeminal. And that's the main content of foramen ovale. But you also have the accessory meningeal artery, a branch of the first part of the maxillary artery, lesser petrosal nerve, and now a branch from the glossopharyngeal nerve that carries preganglionic parasympathetic fibers to the otic ganglion located within the infratemporal fossa for innervation of the parotid gland. Emissary vein connecting the pterygoid venous plexus to the cavernous sinus. After the nerve has passed through the foramen ovale and the sensory and the motor root have met, the nerve divides into two divisions. There's an anterior division and a posterior division. Let's talk about the branches of the mandibular nerve, and we can look at the branches in three entities: the branches before the two divisions, so those are branches from the main trunk, and the branches after the two divisions. So there are two branches given from the main trunk. We have the nervus spinosum, which is also called the meningeal branch. The nervus spinosum is given from the main trunk, then goes back through foramen spinosum to supply the dura mater of the middle cranial fossa. So this is a meningeal branch. The main trunk of the mandibular nerve also gives rise to the nerve to medial pterygoid muscle, which supplies the muscle medial pterygoid, but also supplies the tensor veli palatini and the tensor tympani muscle. So tensor veli palatini is a muscle of the soft palate. Tensor tympani is a muscle of the middle ear. They are all from the first pharyngeal arc. Then we have the anterior division. The anterior division is this one here. The anterior division of the mandibular nerve are basically giving rise to branches which are predominantly motor, which means that these branches largely go to muscles of the first pharyngeal arc. All of them are motor except the buccal nerve, which is sensory. So what are these branches? You'll have branches to the temporalis muscle, which means you'll have the deep temporal nerves, the anterior and the posterior deep temporal nerves, so temporalis muscle. You'll also have a muscular branch to the lateral pterygoid muscle. We'll have a muscular branch to the masseter muscle. Those are the masseteric nerves. So consider that muscles of the first pharyngeal arc are innervated, and especially the masticatory muscles are innervated from this particular trunk. That the only ones, the muscles of mastication, which are not innervated from here, is just the medial pterygoid muscle because its nerve has already been given. So the other three muscles, masseter, temporalis, and lateral pterygoid, receive 4 branches from the anterior division. And I'm saying 4 because remember, temporalis receives 2. Then the fifth branch of the anterior division is the buccal nerve. This buccal nerve is the only sensory nerve. It supplies the skin over that region. All right. Now let's talk about the branches from the posterior division of the mandibular nerve. Branches from the posterior division of the mandibular nerve are predominantly sensory. There are three major branches. The auriculotemporal nerve, which is that one, supplies the skin of the scalp on the lateral side of the scalp there, but also supplies some part of the ear. And remember, it's also general sensory to the parotid stromal tissue. This is the very same nerve that also receives the postganglionic parasympathetic fibers from the optic ganglion to supply the parotid gland. You have the lingual branch, which is this one. As the name suggests, it goes to the tongue as well as the floor of the mouth. This is the very nerve that also receives the chorda tympani branch from facial nerve that carries both taste as well as parasympathetic fibers. And so lingual nerve distal to this point will have general sensory function, parasympathetic function, as well as taste function. But lingual nerve at this point has only general sensory function. Then we have the inferior alveolar nerve, which is this one. The inferior alveolar nerve enters through the mandibular foramen to get the inferior alveolar artery, and it will also supply the teeth, the inferior alveolar, remember, the mandibular teeth. It will terminate out as the mental nerve through the mental foramen together with the mental artery, much anterior. Just before the inferior alveolar nerve enters the foramen, it gives rise to nerve to mylohyoid, which is this one. This nerve to mylohyoid is the only motor branch from the posterior division of trigeminal, from the posterior division of mandibular nerve. This nerve to mylohyoid is the one that supplies the anterior belly of digastric muscle as well as supplying the mylohyoid muscle. So this is the summary of the branching pattern of the mandibular nerve, and that summarizes for us the story of the mandibular nerve, as well as summarizing for us the story of the suprahyoid anterior neck triangles. I hope that you've had a good time in this lecture and that you've tried to understand major concepts that I've highlighted. So we'll stop there. That will summarize for us as well the session 5 series that has focused on neck triangles. You've had the lectures in 3 parts, then be very long lectures. My apologies for that, but we're done with that. So our next series that we'll be calling series 6 will be largely focusing on the aerodigestive organs of the head and neck region. So this will focus on the nasal cavity, will focus on the oral cavity, it will focus on the pharynx, larynx, trachea, esophagus, and I'll break down the lecture in multiple parts as well. The first part will be focusing largely on the anatomy of the nose. All right, thank you very much. We'll stop there.